Hello and welcome to Group 5's presentation by Kelechi Obika, Samantha Ritchie, Anamika Tapp, and Rosalea Murray. Our presentation will be addressing public health misinformation through the health belief model. Stay tuned.
Importance of the research issue. A common barrier in administering quality public health services is the dissemination of false narratives and misinformation. Health misinformation impedes upon delivering adequate public health resources and information within a community. Ultimately, misinformation on important health issues can increase one's susceptibility and ultimately worsen the pathophysiology of a given disease. Administering quality public health services and prioritizing a prevention-first attitude relies upon accurate information being relayed to the affected population or community. Ultimately, delivering quality and accurate information on a health burden is many times the difference in prevention and/or a cure. The health belief model was initially developed around the 1950s by a group of public health social psychologists. These group of psychologists were looking to see why people within their community weren't utilizing free x-ray screenings that they were offering to different neighborhoods within the city. The underlying problem was that many of the people within this community didn't feel that the disease was very relevant to them or to their health. The health belief model comes into play, being that it is a framework mainly constructed of 6 pillars: perceived susceptibility, perceived severity, perceived benefits, perceived barriers, cue to action, and self-efficacy. Conceptually, the health belief model addresses the varying levels to which one's personal beliefs affects how they would effectively address potential health outcomes or concerns within their life. The health belief model approach has been shown to be effective in targeting populations most at risk for a particular negative disease outcome and introduces specific strategies to mitigate them at each level of the framework. The health belief model can ultimately be applied to COVID-19 in multiple different ways. The health belief model can ultimately prove in shifting perceptions of COVID-19. It can address many of the misinformation that has been put out through media in different vessels on COVID-19 and adequate ways of treatment. And specifically, this article goes into how we can implement the health belief model in various different aspects to combat misinformation generally and related to COVID-19. The main crux of this article ultimately highlights the impacts of misinformation and how misinformation can continue to manifest disease in a certain community. In applying the health belief model to health misinformation specifically, we can change the source of how misinformation is generated from an upstream approach. Therefore, moving forward beyond this point, the health belief model will address various different portions of misinformation and how that would affect one's pursuit to healthy health outcomes.
In the health belief model, the focus is on an individual's perception of a threat posed by a health problem and the benefits of avoiding the threat and the factors influencing the decision to act or not act. There are 6 key concepts. Number 1, perceived susceptibility. Believe they are susceptible to the condition. Number 2, perceived severity. The individual believes the condition has serious results. Number 3, perceived benefits. Believe taking action would reduce their exposure to the condition or the severity. Number 4, perceived barriers. Costs of taking action outweigh the gain. Number 5, cues to action. Factors that prompt action. Number 6, self-efficacy. Confidence within themselves to carry out the action. Using the health belief model, The following are positive and negative views of breast cancer screenings. The focus here is older African American women believe they are more susceptible to breast cancer. However, they realize that breast cancer screening is effective in early detection. Key concepts: perceived susceptibility. Be aware that the risk of breast cancer increases with age. Perceived severity. Favorable outcomes with early detection decreases the chances of dying. Perceived benefits: freedom from worrying, reassurance when no cancer is found. Perceived barriers: be aware that a number of factors may act as barriers to screening, but can provide alternative solutions. For example, transportation. Number 5, cues to action, recommendations from healthcare providers. And 6, self-efficacy. Feel increased confidence that women will encourage breast cancer screening amongst their peers. Here is a focus on a negative view: breast cancer screening in older African American women. The focus: older African American women believe they are more susceptible to breast cancer. The key concepts: perceived susceptibility. Older African American women believe they are more susceptible to breast cancer if they had an injury to the breast. Perceived severity. Adherence was significantly associated to the perceived susceptibility. 3. Perceived benefits. Breast self-examination and later mammography. Fear of finding a lump, forgetting to keep an appointment, fear of radiation from mammogram. Perceived barriers: not knowing how to schedule an appointment and not understanding the procedure. Cues to action. In an intervention, Learn, Share, and Live from Skinner and colleagues in 2008, the goal was to change perception and practice, and enable them to address perceptions and constructs. In this intervention, the education sessions with predominantly older urban African American women were attending. The goal of the session was to help in early detection. Program leaders distributed necklaces with different sized wooden beads ranging from 6 millimeters to 28 millimeters in size. This would allow the women to actually see and feel the size of an average lump found during a self-examination versus the smaller sizes detected in a mammogram. To further communicate the benefits of early detection, the program used a dandelion analogy, comparing the importance of pulling up dandelions before their seeds spread across a yard to benefit of taking care of cancer before it spread in your body. They also participated in role plays to address peers' perceived benefits and barriers. They practiced asking friends about their reasons for having and not having mammograms, and then created ways to help friends overcome barriers. Some barriers were beliefs, others were logistical. They were able to come up with mobile mammography units run by local health systems, and some covered the costs for the uninsured. Number 6, self-efficacy. Women's confidence in her ability to complete the steps to a scheduled mammogram.
The health belief model drew no view on vaccinations. Regarding vaccinations, the idea that being vaccinated and suffering the side effects of a vaccine is a better option than having the targeted illness. When comparing it to the chickenpox vaccine, the idea is that having the shot is less painful than having the itchy rash and the other symptoms that come with the chickenpox. Lots of people believe that being vaccinated is a safe choice and protects against illness, and this is also backed up by the CDC. There's a high perception of accessibility for people who choose to be vaccinated. Perceived benefits: being vaccinated protects against illness that could be harmful, if not deadly, to the human body. Being uneducated about vaccines, lack of health care, either due to lack of insurance or accessibility to healthcare services, and personal reasons for being unable to be vaccinated. Cues to action. The HBM has been trying to promote vaccinations while fighting against misinformation in the public. They also have specific groups like healthcare workers and children who are encouraged to be vaccinated even more. There was a high perception of self-efficacy for people who were vaccinated as well. One focus that is now being looked at is the idea that the anti-vaxxer movement. They think that being vaccinated and suffering the side effects of the vaccine is worse than having the targeted illness. And the way this misinformation spreads is through social media or other forms of interaction where these people are seeing this misinformation, being able to retweet it, repost it, or seeing it, remembering it, and rewriting it themselves. One way that we could help stop this misinformation is by educating parents within the doctor's offices and other social facilities like schools or public institutions like the library as well. And then we could have groups monitoring social media for misinformation and having fact checkers on hand to make sure that nothing that is unethical or untrue is being put through and posted online.
In conclusion, one of the earliest and most commonly accepted models of health behavior is the HBM. The HBM is a conceptual framework for improving health and preventing illness. After years of study, experts came to the conclusion that the 6 primary factors, such as perceived susceptibility, perceived severity, perceived benefits, perceived barriers, cues to action, and self-efficacy all impact people's decisions to take action in the areas of disease prevention, screening, and control. The HBM, which was first developed in the 1950s, has seen extensive use in promoting vaccinations. Intentions to vaccinate are positively associated with the 6 key concepts and negatively associated with the low perception of the same, as it appears across studies of vaccination in children, caregivers, and during the H1N1 pandemic. Essentially, the HBM will create and deliver a community-based engagement from health practitioners in order to effectively influence health behaviors and health outcomes.